Hey everybody, how's it going? Wait, kicking off here in just a few minutes. This is fun. I think you guys get to meet with me 4 times in a week. Unusual. Well, it looks like 5 actually. My goodness. Oh no, we have our journal club tomorrow too. I forgot we got a double dose of Epi Bio tomorrow. Hey there. And I think we finished 13 last time, so I think we're starting up on 14 if I recall. So if that's incorrect, let me know. Oh, hello everyone. Up to 16 people, it's pretty good. Hey, Nicole. Hello, hello. Hopefully everyone's studying for the farm exam for Monday and they're feeling good about that. Actually, I posted up all the PowerPoints for the rest of this section for the exam, so those are up there if you guys want to get access to them. I think we'll try to get through 2 PowerPoints today and then 2 tomorrow, and then have our journal club, and then the review will be next week, so should work out. All right, so I'm gonna go ahead and get started with just about 12:30. So, all right, well, hello and welcome. Got 25 of you, so good. Solid third of the class there. So we are going to start off with PowerPoint 14 today. I'll probably do like 14 and 15 today, and then tomorrow we do 16, 17, and then that's like the end of the material for the exam. And then at, I think 2:30 tomorrow we'll have our last journal club. I'll get information and get the groups all set up for that. And then we will do the review next week, and then that final exam will be on that following Monday. So I think everything should time out pretty well. And this is actually, I was able to add in an additional journal club, which is good. So normally I don't get to do 3 of those with you guys actually like actively participating. So that's good. Okay, so let's go ahead and get it kicked off here. And if you have any questions, obviously you can put them up in the chat or on the sticky board. Anywhere is totally fine there. Right, so last time we were talking about how we actually do like investigations of outbreaks and talking about like case definitions, all that kind of stuff here. So now I want to more talk about causation, right? Because it's a difficult thing to determine, and determining like, what sort of things are actually causing a disease to occur. Is something just a risk factor? Like, what are the differences there that we're going to be looking at? And so you can see some of the different things we're going to be covering here in the objectives. So starting off here, as I mentioned, it's really difficult. We'd like to be able to find a very clear cut, oh yeah, if you do this, you're going to get this disease, right? But oftentimes it's not quite so clear cut as that. There's often a myriad number of factors that are going to be coming into this and determining, what a patient's overall risk is for having a certain disease to actually occur, right? So a couple of things I want to talk about are the different types of causal relationships that we talk about in terms of like epidemiology, right? So 3 fundamental types we're going to mention are going to be sufficient causes, necessary causes, and then risk factors, and look at some of the differences between those. So this is going to be sort of a review slide. You can kind of go back and look at that. You should be able to sort of intuit out if you like got a test question what type of cause something is based off of how the vignette's sort of written. So I'm going to get into these in their specifics, but you can refer back to this slide if you want, just kind of a neat little breakdown of them. So sufficient causes, what are those? Basically, this is where cause is preceding the disease and it has this relationship, right? So the relationships here are going to be important. So if the cause is present, the disease will always occur, okay? That means it's a sufficient cause. So as an example there, if you have certain types of genetic abnormalities, especially ones you happen to be homozygous for, then you're going to get a disease, right? So for instance, here is Tay-Sachs disease. If you're not homozygous for that mutation, you're not going to get the disease, right? So that's what we call a sufficient cause. If the thing is there, then the disease will always occur. Okay, so a sufficient cause. We're not going to find a ton of those that are out there when we're kind of looking at more things like epidemiologic concerns, like for instance, like diabetes or heart attacks and things like that. But let's look at the relationship between something like smoking and lung cancer, because I think most people probably know that there is a relationship between there, but is something like smoking considered to be a sufficient cause for lung cancer, right? That's the question. If someone is a smoker, will they always get lung cancer? Well, we're probably going to see they actually don't. And so you can see that it's not a sufficient cause because they can die of lots of other things, right? We know that you can have cardiovascular disease, you can have other types of cancers that can develop there. And frequently you're going to see that, if you had a long enough timeline, if you have these people that were living forever, perhaps they would all get lung cancer. But based off of normal human lifespans, we just don't see that necessarily. So in this case here, we don't really consider it to be a sufficient cause. So just because someone smokes does not mean they're going to get lung cancer, right? Then there's what we call a necessary cause. And so this here would be that if the cause is present, or it has to be present for the disease to occur, but it doesn't mean just because it is there that the disease will occur, right? So in the case here, someone's not ever going to get TB unless they have, this colonization of Mycobacterium tuberculosis, right? It's a necessary cause because it's a prerequisite. But just because someone has tuberculosis or they're exposed to it doesn't mean they're actually going to get the disease itself. They're not going to have necessarily an active case. And we know that. We know there's cases of people who are, who maybe have like a positive tuberculosis test, but maybe they don't actually have active disease, right? So in those cases there, Mycobacterium tuberculosis is not it's not a sufficient cause for TB, but it's a necessary cause. It has to be there as a prerequisite, but it doesn't mean it's going to happen necessarily, right? So in this case here, cigarette smoking is not necessarily a necessary cause for lung cancer, right? Because there are other reasons for people to get lung cancer. They could just have a genetic predisposition to it. They could have a family history. They could have, exposure to things like asbestos and other chemicals. So because cigarette smoking is not a prerequisite to getting lung cancer, we can't really consider that a necessary cause either, right? So again, be able to kind of distinguish between these different types of relationships in order to figure out, hey, is this a sufficient necessary cause or is it something else altogether? And that third thing here, which probably most things get lumped into, is going to be what we call a risk factor, right? So this is, and we've talked about risk factors probably all the time, right? You always talk about it in Clin Med, I imagine. I know I've mentioned risk factors quite a bit in various classes here, but more specifically when we're talking about this, it's some sort of exposure, behavior, or an attribute or something like that, that if it's present, that means it's increasing the probability for that disease to occur, right? So this is kind of the bucket that a lot of other things get lumped into if they don't really fit the bar to be a sufficient or necessary cause here, right? So in this case here, when you're looking at smoking, then yeah, that's absolutely considered to be an important risk factor, because we see that the risk of developing lung cancer can be like 20 times higher in heavy smokers than you might see in other patients, right, who are non-smokers. So because of that, we consider smoking to be a risk factor. So again, be able to make kind of distinctions between those three main types of relationships there in terms of causes and effects. Next up, we want to talk about things like causal and non-causal associations here, right? Again, cause and effect is difficult to determine, but let's look at some of these relationships or associations we can see here. So one of the big things we're going to see as well is that time is really important here, right? To see that something is causing an effect, you have to make sure that it's actually happening before the effect happens, right? So I think temporal relationships are going to be something we'll look at quite a bit here. So again, the requirement for a causal relationship to exist is that there must be an association of interest, right? So the disease, sorry, I'm figuring that up, getting crazy with my mouse. So there has to be an association between the outcome of interest, so like the disease or death that we care about, so like cardiovascular death or lung cancer, something like that, and the presumed cause, right? So again, that's what we're talking about before. Is it a risk factor, or do we see those associations there? And then the outcome must occur either significantly more often or less often in the individuals who are exposed to that presumed cause than those who are not, right? So that's when we're starting to get into things like cohort studies, and we're comparing groups of people based off of their exposure to a risk factor to see, is the disease more likely to happen? Is it less likely to happen? Remember, some things can be protective, right? So you could say like a high HDL is maybe protective against heart disease. That could be a risk factor, right? So again, that pathway has to be there, though, and we can talk about this as either being in sort of a direct or an indirect sort of pathway, and we're going to see there can be some intermediary factors that actually will come into play as well. And so what we're looking at here is that the classification depends on the absence or presence of intermediary factors, which are called intervening variables as well. Okay, so that person that is smoking, if you're trying to find that causal relationship between smoking and lung cancer, you know, is there an intervening variable that's playing a role, such as they work in a coal plant, right? Or they work in a mine where they're breathing in toxic chemicals, right? We can see that there's going to be some things there that may get into, may complicate things a little bit in terms of determining whether something is a causal or non-causal association here, right? So looking at this, when we say a direct causal association, this is occurring under when the factor under consideration exerts its effect without any intermediary factors, right? This means that it is enough just to have this risk factor for something, for the effect to occur, essentially, right? So if I'm looking at something like you know, death from brain damage, you could just have a severe blow to the head, right? You can get into a motor vehicle accident and bang your head against the steering wheel. That's enough in and of itself. You don't really need to have any other factors in there to have someone die from head injury, right? So that can be a directly causal association in that case there. Okay. Indirect causal associations get a little bit more muddy because of the fact that you can have other variables that are sort of playing a role here as well. And I think we probably saw some of this in the last journal club that we did when we were looking at the various disabilities, and they were looking to see the relationships between things like maternal education level and what their income status was and things like that, because of the fact that it's not to say that because your mom didn't go to high school, you're going to have an intellectual disability. That wasn't what they're trying to say there, but they're looking at some of these other associations that may be playing a role here, right? So in this case here, if you're looking at something like poverty, you know, poverty itself, just because you don't have money doesn't mean you're going to die early necessarily, but it does have a huge number of factors there, right? So if you can't afford food, if you have inconsistent access to housing, if you don't get medical care, those are all considered to be intervening variables that occur as a result of the fact that someone is living in poverty. They don't have a whole lot of money there. And so when you see that, that's very important to consider. So it's, again, no one dies from having no money, but it's all the other things that kind of stack up on top of that because of the fact they don't have money. And you can look at various things like that. You can look at, you know, a huge number of things we'll get into, including like, you know, being sedentary doesn't necessarily cause you to have diabetes, but it's a lot of other things that go into that: lack of exercise, diet choices, and things like that, just as an example. And so you can see here too, like looking at education level. So, that would seem to lead to better health indirectly. So just because I'm more educated, does that mean I'm more healthy necessarily? Well, not really. It could be because if I'm pursuing more education, then I'm also going to be more knowledgeable about things like health and eating better, having the adequate income to go to doctor's visits, and I can actually take time off of work to do that sort of thing, right? And so you could look to see like, okay, does education cause you to live longer just because I know more stuff? Well, not really, but it's all the other things that go into that. So hopefully that makes a sense, even though it can be a little bit abstract when you're thinking about it as a sort of like a direct relationship. And again, that's why it's an indirect causal association. So, and when you do that, we can look at these statistical associations. We can look to see comparisons between people with a lot of education versus little education and see their health outcomes and whatnot. To see that an association may be there, we may get a p-value that's low, but again, it doesn't necessarily mean that that is what is the cause for their health outcomes there, right? So again, association does not prove causation. Again, that's another thing that, again, I could ask you that on a test, that'd be a pretty easy question, right? But again, I think it's just important to illustrate it just so you guys remember that, even though everyone kind of knows that, I think, but I think to really drill down to see like what does that actually mean though, right? Because a lot of people see these associations and just assume that there's a causation there, but you got to be a little more critical when you're looking at this stuff. So what we can do though is if we do find a statistically significant association between two variables, then we need to start to do more investigation there, right? So but even if you do find something that is statistically significant, remember that if the cause happens after the effect, then it's not going to be a causal relationship, right? So just because someone gets lung cancer and then they start smoking does not mean that that is associated, right? So again, all of it's very dependent on the temporal relationship between the cause and the effect. Excuse me. All right. So here's some more examples here. So for instance, like estrogen treatments for postmenopausal women, we saw that they were starting to be associated with endometrial cancer. In a lot of cases, they were considering this to be the cause of the cancer, right? And so again, this is kind of before we had more information on the topic, we did more research on it. But at the time, they thought, okay, well, estrogen exposure is the cause of endometrial cancer, right? So then anyway, we're doing, studies and whatnot, and then it was realized that the estrogens were given to control early symptoms of undiagnosed endometrial cancer, right? So in this case here, these women already had early signs of cancer, being things like spotting and abnormal bleeding and whatnot. And then they were receiving estrogens because they thought it was menopausal symptoms or something, and then they discover the cervical cancer down the road, right? Or endometrial cancer, I should say. Apologize. So because the estrogens were coming after the cancer, then you can't really say that's a causal association, right? So I think it pretty makes intuitive sense that there has to be that temporal relationship there. They're finding some cases in which estrogens came after the cancer had already started. Again, the presumed cause was prescribed after, and again, it was due to that cancer in the first place. So they got the cause essentially because of the effect that was already happening. So that doesn't make sense there. So sometimes you're going to be able to find that there could be an association there, but again, you have to establish, okay, well, the actual effect you're looking at, the outcome was not there to begin with. Okay. All right. So again, if we're doing a statistically significant association, we find that, yeah, it looks like there's a low p-value, there's something here. But if there's some other factor that causes the presumed cause and the effect, then that association then is not causal, right? And that kind of doesn't sound sensical, but when you look at it here, so for instance, if you were to look at people who are bald, you could then look at also their outcomes for coronary artery disease and say, wow, it looks like there's an association here. Bald people are more likely to have coronary artery disease, right? Even though, functionally that doesn't make any sense, right? But could there be something else that's leading to that? Well, it's probably having to do with something like the hormone. So again, just because you find an association does not mean that that is anything there, right? So if you actually look deeper, then you'd be able to find that, well, okay, there's actually another association here that high levels of dihydrotestosterone, which these patients are more likely to have, or patients that have high levels of DHT are more likely to be bald and also have coronary artery disease. Okay, so again, you can see that the actual cause was another step back, and the actual relationship between baldness and coronary artery disease wasn't really. There's no actual relationship between those two because they share the same cause essentially. Okay, so how do we determine this, right? So how do we determine actual cause and effect here? And so there's some ways we can do this, right? So there's kind of 3 steps to this scientific method that we go with. So we have investigation of the statistical relationship, right? So you actually have to do the comparisons to see, is there something here or is it just due to random chance? Then we have to look at the temporal relationship, which I've been mentioning here, and then elimination of all known alternative causes, right? I missed a word here. So by eliminating those, then you can say, yeah, there's definitely something here, right? So it's kind of like being a detective a little bit and trying to say, okay, well, let's rule out all the other stuff, make sure it wasn't the candlestick in the library. We have to actually make sure it was the gun in the study or something like that, right? Going back to my clue references. So let's talk about these investigations here. So the initial investigations, they can test hypotheses, right? So you come up with a hypothesis saying, hey, I think there's an association between these two things here. You could either do this as looking for risk factors, or you could be looking for protective factors too, right? So either things that are going to increase the risk of something happening, or something that's going to decrease that risk of that thing happening there. And so for it to be identified, right, the presumed risk factor has to be present significantly more often in persons with a particular disease of interest than those without the disease, right? So this is like when you're doing your cohort studies and you have people that are lumped into one category that have the risk factor and then people in the other category do not. And then you'd follow to see who actually gets the disease, right? And then by doing that comparison, like a t-test or something, you can see, okay, well, these differences here are statistically significant. The people had the risk factor had a statistically significant higher likelihood of having the disease. Thus, there's an association here, right? So that way you can say, okay, these are at least association. Again, I don't know if it's cause and effect just yet. And so again, the difference has to be large enough to be able to say that, yeah, this is not just due to random chance here, right? Or in cases, if you're looking at protective factors, like maybe you would look at, if you were doing a study and looking at people who got the flu vaccine in 2020 versus people who did not, and then looking to see who actually got the flu, obviously you'd expect rates to be higher in people who are unvaccinated than otherwise. And so in those cases there, you'd actually be looking for decreases in the outcome. So that's how a protective factor would be kind of measured there, right? So then once we have, or in the presumed factor, whether it be a risk factor or a protective factor there, if it's not associated with a statistically significant frequency disease, then we can't really consider it to be causal, right? If the differences in the groups there are not sufficient enough to be considered statistically significant, if that p-value comes back at 0.1 or something like that, then we can't necessarily say there's an association, right? Or maybe there's something, maybe there's a methodologic problem with the study. Maybe I didn't have enough people, it was underpowered. Who knows? Maybe it was a type 2 error. But at that point, I cannot consider there to be a causal relationship here, right? So something else could be obscuring though, right? So maybe you didn't take into account certain features. Maybe you have some kind of bias that's being introduced in the study. Who can say? We don't really know at that point though. But if that occurs with proper research design, then that statistical analysis should be able to show the difference. So if you're able to control for all those other variables, it could be muddying the waters a little bit. So for instance, if you are excluding people that might be biasing the data from the study, then you get a more pure signal, so to speak, right? So you kind of eliminate some of that noise to get just the signal, do it to see if that association is there and true or not. So when we're doing epidemiologic studies here, that research design that we're going to be using has to allow for those associations to be shown if they actually do exist there. As I mentioned, we can either do things like comparing rates of disease before and after an intervention. So like say rates of disease prior to a vaccine being introduced versus after, or compare the groups with and without the exposure or the treatment, right? So you can kind of do like a pre-post sort of analysis, or you could do it at the same time where you have two groups of people who either have the exposure or not, and then follow them for the outcome. So again, the study designs are a little bit different in those cases there. And so we need these analyses, the statistical test, to actually show that the difference associated with that intervention or that exposure is much different than what it would be without the exposure, right? So I'm looking for differences that are quite large to be able to show a statistically significant result. So that way the p-value is less than 0.05, right? And again, the bigger the change, the easier it is to find, right? Like kind of the example I was using with someone else is like if you were trying to find a tool out in your garage, it's a heck of a lot easier to find, a lawnmower than it is to find a screwdriver, depending on how messy your garage is. So again, that's what we're looking for here. So if we do find a statistically significant difference in risk of the disease is seen, right? So the actual risk for the disease goes up if you're exposed to the risk factor. Then we have to kind of consider some of the following questions here. So did the therapy make patients better or worse on average, right? So do we see that maybe admittance to the ICU has changed as a result of using a new therapy for something? Was the difference large enough to be etiologically or clinically important, right? That's another thing we talk about a lot with clinical importance or clinical significance, is if it makes, a 5% change in the risk of something happening, does that matter to you, right? So if it's 5% difference in the rates of death, then perhaps that does mean something, right? So that's going to be up on a clinician to clinician sort of basis there. And then even if the difference is observed and we find statistically significant, a big change here, just because you find that statistical association, again, does not prove causation, right? Could be other things are going on there, and that's what we have to be looking for. And so again, it may initially seem like that association is causal, just like with the endometrial cancer and exposure to estrogens, even though it was later found out to be not the case, right? And this is why medical medicine is constantly changing. The things that I teach you today may be totally outdated 5-10 years from now, maybe 2 weeks from now, who knows? So you got to be able to go back and kind of throw away old assumptions when new data comes out to sort of refute those things. Okay, so being open-minded is very important, and not something that is you'll see very frequently in some providers, as you might see on your rotations and whatnot. But regardless, several criteria that if we meet that statistical significance to actually show that the relationship is causal. And so this is something called Mills canons that are sort of outlined, and these are things we're looking for to be able to show a causal association here. So these are some of the things. I think I talk about this. I'll just go through these real briefly here. So basically they're saying if these things are here, if they're present, and the more that are present, the more likely it is that there's actually a causal association here, right? So is there a strength of the association? Do we see a large difference between the groups based on exposure to a risk factor, right? Is there consistency of the association? So if I were to run that experiment 10 times, would I get the same results every time, right? So the more consistent it is, the more likely it is to be a causal relationship. Looking at the specificity of the association, right? So if we remove that risk factor, do we get rid of the association, right? So missing that risk factor should eliminate the association. If that's true, then that would lead you to think, yeah, there's probably more of a causal relationship here. And then what's the biological plausibility of the association, right? So based on the kind of current knowledge that we have. So someone being bald, does that mean they're more likely to die of a heart attack? Well, that doesn't make sense physiologically unless you knew about things like DHT. And then by having that alternative, you could eliminate that linkage between baldness and heart disease. And then another thing we all look at as well is the presence of a dose-response relationship. So the more of a risk factor they have, does that mean that they are having a bigger difference there? So the greater the effect. So if I have someone who smokes 1 pack a day, is their risk of lung cancer much less than someone who smokes 10 packs? I don't know if someone could actually smoke 10 packs a day, but say someone who smoked like 3 packs a day. So that's sort of the things you're looking for. If you can show all of these, then yeah, you're pretty confident that there's a causal relationship here. If you only have 1 or 2, then that may lead some things to be left in question, right? So the next thing we'll look at is that temporal relationship, and this can be difficult to see here. So, for instance, getting the time frame for when someone has been exposed to a risk factor versus when the disease occurs can be challenging to figure out unless you are doing certain types of study designs, as you'll see. So again, proving that is complex unless we have like some kind of experimental control that we're doing here, right? So if we go ahead and have a cohort study where I know these people have never been exposed to the risk factor before, and then I look for the outcome of the disease. But think back to when we were talking about the developmental delays or developmental issues we were talking about at the last journal club, right? So we said that it looked like with moms who had a higher degree of education, there was some linkage there, or, but what if we, their kid got diagnosed with a developmental issue and then mom went back to college afterwards, right? That cause and effect sort of thing there, that temporal relationship is difficult to determine if you're just doing a study at a single point in time because you're just getting all the data points there unless you ask, you may not know, right? So that's why it's difficult to form temporal relationships with things like surveys unless you get very kind of specific about it. So some other examples here too, like with chronic diseases, again, the onset of the effect is frequently not really clear. So if someone has a heart attack at 45, well, when did they start developing atherosclerosis, right? Was it back when they were 25? Was it back when they're 40? Like who can really say? It's difficult to know. Or when did that first cell become cancerous? That's impossible to tell. And then the onset of the risk factor also may be difficult to determine. A patient may go in, they may not go see a doctor for 10 years, and they go in and they have high blood pressure. And they say, well, okay, well, how long have you had high blood pressure? And they're like, well, I just found out today. So who knows how long they've actually had it for unless they're actually checking it, because, something like blood pressure is generally asymptomatic if you're hypertensive. Or when did the diet, quote unquote, become unhealthy, right? So these are things that are difficult to determine unless you are actually controlling for those sorts of things with statistical design or their study design there. And so because of the nature of a lot of these risk factors having sort of varying amounts of latent periods, right? You can have a long time where you're exposed to something before the actual outcome occurs. Again, it can be obscured, right? So, or for instance, with certain things like obesity, right? That's a chronic disease that can cause things like osteoarthritis, right? So the more you have wear and tear on the joints because patients are overweight, but that leads them to be more inactive. And so then they're more inactive, so then their weight goes up, and then that worsens the osteoarthritis, right? So again, the obfuscation of the actual relationship there is challenging because one kind of worsens the other there. And so that's, again, why I say research design is so important, because they're able to sort of control for those sort of things and actually determine those temporal sort of relationships there, right? And again, that's more challenging. Like you can't really do that with something like a case control study, because the people already have the disease, and then you just ask them, hey, do they have the risk factor or not? The time frame is really hard to figure that out. Versus if you do like a cohort study where you start the association, or you start the risk factor in one group and not the other, and then you can follow it to determine that. But again, those studies are harder to do. They're more expensive, time consuming. So that's, again, research is hard, as it turns out. So as I mentioned, the surveys is difficult because it's really hard to determine when something actually started or not. However, some things are pretty easy to tell, right? So someone's gender or race may be present from birth, right? Even that can be challenging sometimes too, right? So gender identity is something that hasn't really been taken into account in a lot of types of studies, as you'll see. But maybe that's something that may, and that can be fluid, that can be changed over time. So maybe that's something we'll have to look at in the future potentially, right? And again, so some of those things are easy to determine, or easier to determine because they're present at birth. And so then if you just kind of line that up with when the actual effect occurred, then you can see that. But with a survey, it's very difficult to determine that, or just a single medical visit to see what came first, the chicken or the egg, so to speak. So one of the things here we'll look at, so like prenatal care, this kind of illustrates some of those challenges we run into when trying to figure out these sort of temporal relationships here. So what we see here is that with every analysis of prenatal care, it does show a positive association between the number of prenatal visits and the health of the infant. And that is oftentimes going to be either determined by survival or looking at like the birth weight of the child, right? And so if you even control for things like socioeconomic status and education, all of that, you still find an association. The more visits you have, then the healthier the baby is, right? So it'd seem like, okay, well, let's just go ahead and start scheduling like daily visits for these patients here. No, you can't really do that, right? But it would appear like, okay, well, the more visits you have, the healthier that baby's going to be. So is that really the case, though? However, what we can see here is that there are some complicating factors with that, right? So generally speaking, when you're looking at prenatal visits, they increase in frequency the nearer that patient gets to term, right? So for instance, when they get to 28 weeks, it'll be biweekly visits, and then it'll be weekly for the last 4, right? So they're getting a higher frequency of visits towards the end there as they get to their full term, right? So that's all well and good if you have a delivery that ends at 36 weeks because you have all those visits there, right? But if you went to 40 weeks, you'd have even more visits, right? So would that baby be healthier necessarily? Well, or what if that baby's born at 28 weeks? Well, they're born at 28 weeks and you end up missing all those additional visits there. So again, the association, again, obviously a baby born at 28 weeks is going to be less healthy, at least from a birth weight standpoint, than one that's born at 40 weeks. So again, that's a complication there to see, like, okay, well, is it the visits that's actually causing the increase in health, or is it because the mom that was carrying for a longer period of time that they just happen to get more visits for that? So again, it's difficult to make those associations, or you see the association, but it's hard to say that there's actually cause and effect there between them, right? So looking here, you can see, labor-inducing condition, right? So whatever's happening leading to labor early, sees preterm to visit or preterm delivery is leading to that low birth weight, but also causing the reduced number of visits here. So even though you're looking for a cause and effect relationship between the visits and the birth weight of the baby, we actually see that ultimately it's due to the fact that they were delivered early, okay? So again, this looks like a clear association. And there is an association, but it looks like clear cause and effect when that's not really the case. So again, this is why we have to look for alternative causes for this that could be intervening here, right? So going back into eliminating all of those known alternative causes here. So when we're doing these associations, we have to make sure there's no other likely explanations for the association, right? And so research design can help us out with that because we can control for things like age and gender and ethnicity. We can make sure that our groups look similar to one another, or we can make sure we do good randomization procedures, right? So we make sure that we don't have any kind of like selection bias where people are getting put into groups either by the investigator because they're like, oh, well, this person's more sick, so I want to make sure they get the active treatment, right? You don't want to have that kind of thing. You want to make sure that randomization procedures are being held, are being actually adhered to, right? And so you can see that, also means with the treatment and control group should be reasonably comparable in regards to their disease susceptibility, right? So you shouldn't really be seeing a higher likelihood of people having a history of heart disease in the treatment group versus in the placebo group. They should be relatively equal to one another if the randomization actually took place, or as it should, right? And so again, this is part of the efforts that are made by the investigators to reduce that measurement bias and other potential problems. And we're going to talk a little bit more about measurement bias here in just a little bit. And again, also you want to also look at things like, the number of people lost to follow-up, and again, all those things that could be influencing your data to some degree. So in that criteria where we're trying to get rid of all those alternative explanations, you may never be able to get rid of all of them, right? Because the second you think of something else, then that's something the researcher didn't look at. So it's almost impossible to get rid of every single alternative because you could think of some pretty wild things for sure. But let's look at some examples here. So classically, we thought about peptic ulcers were due to things like stress and hypersecretion of acid and whatnot. And it wasn't until someone really challenged the theory that H. pylori was actually causing these ulcers there. And if you haven't looked up the there's some YouTube videos, I think a documentary about there's an Australian physician who was really bucking the trend, and he was really like, no, I think there's something here with this H. pylori, and everyone basically shut him down and said, nope, this is not the case here. So what did he do? Well, he drank some H. pylori, gave himself a stomach ulcer, and then he took antibiotics, and then they went away, right? So pretty interesting case, not something I would recommend for most people due to manage themselves, but go look up some YouTube videos of that. It's pretty interesting. I think the guy got like a Nobel Prize based off of that because, again, if you don't investigate these things, you just don't know, and then you go on thinking for decades that this is the only way things are going to be, and that may not be the case, right? So again, having an open mind is really important to be a good clinician, to be able to reevaluate your previous held biases and be able to accept new information to change those as needed. Yes, absolutely a mad lad for sure. Plus he's Australian, so he's fun to listen to as well, which is nice. But let me see here. So anyway, when we're looking at those explanations, they're always tentative. There always could be something else. So again, keeping an open mind is super important there. So let's talk about some pitfalls in causal research. What are some issues that we can run into? And so bias is going to be a big one. And remember, bias is, not necessarily always done on purpose. A lot of times this is due to like bad study design. Oftentimes, we try to eliminate bias wherever we can, but it's always going to kind of creep in to some degree. But it's an amount of like actual error in the epidemiologic research. It's the amount of And when I say error, I'm not talking about the variability in the data. I'm talking about actually skewing the data one direction or another here. And it causes these deviations, these distortions that tend to either weaken a true association to maybe where we don't find a statistically significant association when there is one there. It may produce spurious associations where we think, yeah, there's something here when actually there isn't. Or it can sort of distort those apparent directions of the associations between variables, right? So anything that's sort of clouding the data or introducing more noise to that signal, so to speak, is introducing bias. And there's so many sources of this. I'll probably give you plenty of examples going through this, but we'll be able to categorize them as either assembly bias or detection bias today. So assembly bias here is going to be sort of our first, our first step here when we're doing trials is to make sure that we are getting our group of patients, right? So how do we get the patients and how do we put them into their categories to make sure that everything is even and we're not introducing bias, right? And so if you're looking at some things here, consider like who volunteers themselves to be in studies, right? If you think about, if you hear on the news, or it's not on the news, but if you listen on the radio, you hear something like, hey, there's a new depression medication, we'd like to have a clinical study. There's already an inherent amount of bias there in the first place. You'd have to be enrolling someone who is actually adventurous enough to try a brand new drug, right? Or to try something like a clinical trial. So again, there's a lot of sources for this. We'll talk about some ways to mitigate that as best we can. But that assembly bias is if you were to see that you were to have issues of like who the actual people are in those particular groups there. So again, if you are looking at the characteristics of the intervention group and then those of the control group, if they're not comparable, that's already introducing bias. So that's when you're looking at various studies, and you'll look, there's usually a table in there that will actually compare the demographics of the control group versus the experimental group. And the point of that is to show that they are quite similar. Sometimes they'll do actual statistical tests to show if there's any associations, but frequently you can just kind of eyeball the numbers to see like, yeah, it looks pretty similar. They had roughly the same amount of male versus female patients. The ages look roughly similar. That way you can kind of eyeball it and think, okay, yeah, this is probably, pretty even groups here. Now again, if you don't have that, if you have groups that are kind of lopsided in various degrees, that it itself can cause an intervention, right? So, or can lead to an effect. So, for instance, if you were looking at outcomes of, say, myocardial infarction in a study, and the control group had a higher number of people that were older, then that would skew the data, right? That would skew it because those people are more likely to have heart attacks anyway than people that were younger. So again, that's a form of assembly bias you're introducing because the group, it's not really apples to apples that you're comparing anymore at that point, right? So when you can kind of break down assembly bias into a couple of things here. So selection bias and then allocation bias, and that kind of makes sense when you see the names there. But selection bias is typically going to be when subjects are allowed to sort of select what group they want to be in, right? Typically, patients who are more likely to volunteer themselves for these types of studies, more educated, more adventuresome, they may be more health conscious, that they want to try something new potentially. And so just because these people may be more healthy to begin with, that again can skew some of the results there. And again, almost any non-random method of allocation is going to be introducing bias. That's why it has to be randomized. And I'll tell you, like, this can be pretty heartbreaking in some cases here, depending on the disease state. Looking at, for instance, doing research with spinal muscular atrophy, which is very often a fatal disease for these young children, their parents absolutely want their kids to be on the experimental side because they know that if they're getting control, if they're getting no drug, then they're not making any headway. They're not making any forward advancement. And so to see the looks on their face when they're just trying to figure out, because you're carrying the drug, if I carry the drug down to for the provider to administer, and you see the looks on their faces are like, okay, is it drug? Is it active drug? Can I tell? It's just, they just want to know because they really want their kid to get better, right? So if you don't randomize for that sort of thing and then everyone got to pick where they went, then obviously that would skew the data. So anyway, and so selection bias can also be found for treatment for things like terminal diseases. So that was an example there. And you may see that more severely ill patients want to try that new treatment. So just like these parents want their kids to get better, they are more likely to try some of these experimental drugs here because that's providing some hope to them, right? Some hope that might not have been there otherwise. And And so again, because of that self-selection, new treatment might be given to patients who are the sickest, and they might also have more poor results, right? So if you're giving it to more sick patients in the first place, they're probably more likely to have poor outcomes, and thus that again is introducing bias there. So you can't really compare those fairly if you were looking at patients who maybe were getting the control and they were not as sick. So again, selection bias is no good. That's why we have to randomize. Allocation bias is going to be more so where the investigators choose that non-random method to assign subjects to a study, right? So selection bias is going to be more so where the actual people being introduced into the study, and if they're allowed to select which group they get into, selection bias. If it's the researchers putting people into the wrong groups and not randomizing, and then that's going to be more allocation bias because they're the ones who are actually allocating the patients to which group, right? And this can occur, if you have people that are not following the clinical trial, because remember, frequently in studies, there's a lot of people involved here. There's research coordinators, nurses, providers, so a lot of people get involved here, and if not everyone's following the same steps, then that again can introduce bias there. And so they had one study where investigators thought patients were getting randomly assigned to care on either a teaching service or a non-teaching service, right? So the teaching service meaning you'd have like residents and stuff who were following the cases versus non-teaching being like your general hospitalists, people who already have been through their residency training, right? And so what they were finding is that that randomization process wasn't actually being followed there because they found that more interesting cases were being sent to the teaching service, right? Which makes total sense because, they're still learning and they're still training. And so they want to see the interesting stuff, but that skews the data because maybe those patients are sicker and it looks like being on a teaching service has worse outcomes than a non-teaching service when it was actually a form of bias that was being introduced there. So again, you have to resist that pressure to put people into certain groups just based on either your heartstrings being tugged, the patient's trying to bribe you, all those sorts of things there. So randomization, very important. So, and then we talk about some of the issues of validity, right? So there's something I'll talk about called internal validity and external validity, right? So internal validity basically means that the study is done in a way that actually makes sense, that it was done to good statistical design or good methodologic design. People are randomized normally, you get the results, the tests are done correctly, you're using non-parametric tests when you're supposed to, all of that, it makes sense, right? So that's internal validity. You want to have that for sure. External validity is going to be like, well, how does this really stack up with the real world, right? So if I do a study and I'm looking at how good a drug is for, I do a study, I'm only looking at, white males age 40 to 45. And then I published the results and I said, look at this awesome study. It's great. The internal validity was awesome, extremely well done, statistical design, everything's good. But then it's like, well, how applicable is that to any other patient other than a white male that's age 40 to 45? It's not really, right? So because of that, it lacks external validity because you can't really apply it to anyone else there, right? So that's when we talk about that generalizability of a study. How generalizable is it to your particular patient? That's what you care about, because if you're working with, say for instance, you're working in Orlando and we have a high, Latin population, and you find our Hispanic population, and you find that the study you're looking at doesn't really capture a lot of those patients because maybe it was done out in the Midwest somewhere, or that they have a lower, lower likelihood to have Hispanic patients, then it may not be as generalizable anymore, right? Because again, you want to be looking at your specific type of patients. And so again, you have to keep that sort of thing in mind there. So keep in mind about that sort of, validity there. But anyway, so you want to have studies that have internal validity, but they may not always be externally valid to the patients that you're looking at, right? They may not be generalizable. Okay, so then we have some things like detection bias. So we're looking at selection bias here. Now we're getting into detection bias. So looking at this, so this is basically where we are having issues in terms of actually collecting the data, right? Or there's something skewing the data that we're actually collecting there. And so we want to make sure that we eliminate these sources of bias, and we're going to look at a few examples of these. So let's say we're doing a clinical study, investigators are focusing on detecting and measuring causal factors for something like disease or death, like heart attack, for instance. They want to look at things like high-fat diet and smoking and whatnot. So they need to be able to make sure that they collect the information correctly, make sure that patients are reporting things normally, if the lab values are done correctly and all of that, to make sure there's actually a causal relationship there, right? Not just that there's an association. So they want to make sure those associations and the differences they're observing are not attributable to issues of measurement bias or things like recall bias and other forms of detection biases. We're going to get into this here. So we'll look at these examples going forward. And so you can find detection bias can kind of be when you have this introduced into a study, it can lead to either failing to detect cases of disease. Maybe you don't detect certain causal factors there, or maybe you don't find certain outcomes of interest. Okay, so we'll talk about more specifics on what this is. So let's look at an example of a study of lung disease, right? So we're going to do a case control study, and we're doing case group is consisting of individuals receiving care at the pulmonary service of a hospital, okay? And then our control group is going to be consisting of people who are individuals just in the community, right? And so what we find is that early disease among these controls can be missed because they're not receiving as intensive of a medical care as the hospitalized patients are, right? So these people from the community, they may not have seen their doctor or their provider for the past 10, 15 years or something. And so maybe they do have lung cancer there, they just haven't been detected yet, right? So it's a form of detection bias. So looking at these true differences here, you would find that between the cases of controls might be less so than the actual apparent difference would be, right? And so, it may be detection bias if the two groups of the study subjects have large differences in their rates, or if there's like a loss of follow-up too, right? So if those people in the community decide to drop out of the study or something, that may lead you to having also some detection bias of cases of lung cancer then as well, just because they weren't around to actually be measured. And so, what we can do here, so in some clinical trials, we know that subjects are allowed to leave studies. No one's being forced to as part of the ethics of doing research here. You see they may be responding more poorly than other subjects, and that's why they tried to leave the study, right? Maybe they were getting a treatment and they felt worse while they're on it and said, no, I just don't want to do this anymore, and they leave, right? Or if they're sicker, they may try other therapies. Maybe they're going to try some alternative medicine. Maybe they're going to try some acupuncture or something to try to augment the other things that they're on. If you don't detect those sort of things, then it could be introducing bias. Or in some cases, you may find that clinical trials, you may have subjects lost to follow-up because they respond the best. If they feel better, they say, all right, I'm great, I don't have to worry about taking this medication anymore, then they leave this trial, right? So again, a lot of reasons why people may be lost to follow-up here that, again, can introduce those biases of detection. For measurement bias, so this is going to be something where the actual measurement of different variables are going to be skewed one way or the other, right? And so you're probably wondering, why do I have this shoe that has a tiny aquarium in it? Well, imagine if you're trying to do a study where you need to measure heights of people, right? And you had multiple people who were doing intake on these patients here and measuring their heights. And you can see that if you're not forcing everyone to have the same procedure to make sure they take their shoes off, then you may find there's a lot of variability in there. So if you had, say a gentleman coming in wearing a shoe like this, then that's obviously going to skew their height up by a few inches versus if they came in wearing flats, for instance. So it really all depends on making sure that everyone is measured consistently. So everyone has their shoes off, for instance. If you're measuring weight, make sure that it's if their clothes are on, that could affect it. So maybe in the summertime, weights go down versus in the wintertime because you're just wearing more clothes, for instance. So all of that is a form of measurement bias. And so some other things too, imagine blood pressure values, right? So we can introduce bias here if some investigators are using cuffs that measure them incorrectly, and that can cause them to be higher or lower. So if you're using the wrong size cuff, for instance, that can affect it. If you're doing like a wrist blood pressure measurement versus an actual cuff on the arm, that can introduce bias there. Yeah, maybe something Elton John would wear, who knows? So anyway, so you need to make sure that everyone's doing things consistently. Like I think about temperatures too. Like if you're measuring temperatures, making sure if you're doing rectal for one person, they have to be done for rectal for everyone. Or you don't want to just mix it up because that can skew the temperatures up or down depending on the situation there, right? So again, they have to be adjusted based on those standard normals from each laboratory too, if you're doing laboratory exams, because you may find the different labs can even introduce some bias into the results they have there. So making sure they're using the same reagents, the same testing method, all of that can make a difference there. Like an example here for like labs that can introduce bias, like if you're doing something where you're measuring like serum osmolarity, right? So if I was doing like a study on patients who drank, isopropyl alcohol or something like that, or radiator fluid, we measure things like osmolar gaps, where we actually get the patient's serum osmolarity, and then we have to see basically compare that to what what we'd expect to be based on their lab values. There's two different ways to get serum osmolarity. There's freezing point depression, and then there is melting point, or was it evaporation point elevation? One of those two, right? There's two ways to do that. If you do it one way, you actually end up heating up the sample, and the alcohols evaporate off. And so you get bum measurements because of that. If you do freezing point depression, then you're able to get accurate results there. And so if you have different labs doing different things, then that's going to skew your data. Just as an example. Recall bias is going to be something, as you might imagine, where patients may not recall all the details of their life to the degree that you'd like them to, right? So if subjects here have experienced an adverse event, they're probably more likely to recall that than someone who had never had any issues with a particular treatment, right? So if they had a bad surgery and now they had a bad outcome from that, they're going to likely remember that a lot better than someone who had no issues at all with a surgery, for instance. Memory is an imperfect thing for anyone, even on their best days. And so people always forget some information, and that can certainly be affecting things for sure. And so when you're looking at recall bias, it's basically where people are forgetting things or not mentioning things because, they just forgot it. So for instance, here, if you're looking at recall bias here, it's a big problem for things like congenital abnormalities or congenital anomalies here, because moms who give birth to an abnormal infant, they tend to think a lot more about their pregnancy, right? They remember almost everything they did. Did they have any infections? Did they take any medications? Oh, there's one time I took ibuprofen. Could that have caused this? Any injuries, anything like that? They remember a lot more details because frequently they're looking for reasons of why their child was born with a certain abnormality, right? Versus if you had a relatively uneventful pregnancy, you might not think about that stuff. You might not recall a lot of those details there, like if you took any medications or if you had an infection or something like that. And so what you can see there is it produces sort of a spurious or sort of a falsely positive association for a risk factor when really there wasn't something there in the first place. And it could be an association where they may not even be linked to one another, like respiratory infections and having a congenital abnormality, right? So again, those are things you have to be looking at. So either people recalling too much or too little, as the case may be. Now, certainly there's just random error too, right? So that's always a possibility for a lot of studies. And again, these can lead to findings that are too high or too low. But generally speaking, if you have good randomization procedures, they can tend to cancel each other out. So random error is usually less serious than actual bias because it tends to cancel out, assuming you have enough people. In a study, small sample sizes leads to more random error being introduced because, you don't have people to cancel one another out. But it can reduce the probability of finding something, especially if you're trying to find like a small effect size, or there's not like a great change between group to group there. So more random error, the lower statistical power you're going to have to actually find a difference, basically is what I'm saying there. Again, you can overcome that by having more people typically. Now, confounding is basically where you're going to have something that's going to be confusing the associations that you're seeing there. So you look at two variables and you think there's actually a causal relationship there, right? So you at least think the part of the effect that we're seeing, the outcome we're seeing, is at least impartially due to the risk factor, right? So looking at this, we can see that if you're looking at like percentage of gray hairs on the heads of adults, you can see there's an association between that and the risk of MI, right? You can see that, and again, just like the baldness and coronary artery disease, that there's probably not going to be a causal association there. But we do see that age is likely confounding that, right? So if you don't control for age, then you're going to be able to find sort of these spurious associations there, right? If you're able to control for that sort of thing, what I mean, you're taking the effect of age out of statistical examination. If you don't do that, then you're going to be able to find the confoundings affecting your results. It's going to be biasing your results. So, for instance, here's an example of confounding where women who had high parity were found to have lower rates of breast cancer, right? So they're looking at that, they see this association. So the investigators assume that childbearing was actually protective against subsequent cases of breast cancer, okay? They discovered that a best predictor was actually that childbearing at an early age. Okay, and so when they actually took into account the age at first delivery was entered into their analyses there, they actually found that the number of offspring they had didn't matter. But the fact is that people who often have more kids probably started earlier. So just looking at the number of children they had and the rates of breast cancer looks like an actual association. But when you take out that confounder of age at delivery, or in this case here, if you're just looking at age of first delivery versus breast cancer rates, and you take out the effect of the number of children, you see there's no association there anymore, right? So you can kind of do it either way. So again, that's a confounder. You want to be able to control for confounders, at least common ones, when you're looking at that. So that's why when we say, there's an increased risk of death after controlling for age, that's saying something, because it says it doesn't matter if you're older or younger, there still is an increased risk of death based off of XYZ risk factor, right? So there's an association, but it's probably not going to be causal there. So again, if you can look at this example here, high parity, risk of reduced risk of breast cancer, it looks like there is a causal relationship here when really all it had to do with being young at your first delivery, right? So now there's some other things here. We'll talk about things like synergism. So this is actually an interaction between two or more presumably causal variables, but it's actually that the combined effect is greater than the sum of the either one by themselves there, right? So obviously you know what synergy is. But looking at something like lung cancer, you can see that that risk of that is going to be greater for a person who has exposure to asbestos and smoking than it would be if you had either one of those by themselves. So sometimes things tend to ramp each other up a little bit to increase that risk even further, right? So they're kind of more multiplicative than they are additive in these cases, okay? Now, another thing we'll talk about here too is called effect modification, or sometimes called effect interactions. And so this is where you can see that certain effects may modify that risk when you're looking at an association. So looking at the direction or the strength of the association between two variables, so looking at a cause and effect here, is being influenced by the value of a third variable, right? And so it's called effect modification, and sometimes effect interactions. As you'll see, it just depends on who you're talking to. So if you're looking at a biological example of effect modification here, the example they use is Epstein-Barr virus infection being manifested in different geographic areas, right? So looking to see what those rates were. And so they found that the virus usually results in infectious mononucleosis in the US, which most of you guys are familiar with that. But in areas in Africa where the malaria is more endemic, they actually find that it leads to Burkitt's lymphoma. You're like, okay, well, it's the same virus. Why is it leading to these different things here? And so what they wanted to do is actually test whether malaria is an effect modifier that leads to this outcome of Burkitt's lymphoma here, right? So what they ended up doing was instituting a malaria suppression program in this African region, and where they, found Burkitt's lymphoma was usually pretty prevalent there, and they followed for the new cases, right? So they did a pre and a post sort of design there, and what they found was, and when they suppressed all those mosquitoes, they actually, in suppressed cases of malaria, that the incidence of Burkitt's lymphoma was actually decreased, right? It was suppressed, although even other factors seem to be totally normal, okay? So that's in a case of effect modification. The actual malaria in the area, those rates of malaria, was the effect modifier in this case here. So here is another little table that will kind of illustrate the different things we talked about here between effect modification, synergism, and all of that. So you can refer back to that for your studying pleasures there, okay? So that's it for this section. I'd like to get into the next one, if you all will stick with me. If not, I don't really care. I'm going to keep talking anyway to myself, because that's kind of just my job nowadays. Okay, so that was number 14. Let us open up 15. You guys should see this on Canvas, I believe. If there's any questions. No questions here. I know I'm just doing an awesome job of explaining all of this, and so you guys have 0 questions. Perfect. Let us go. Oh, actually, I have an update. I don't want to toot my own horn, but got to celebrate small victories here when in COVID times. I actually got a promotion just recently. So I'm actually now an associate professor. So that was something that recently happened. So also congratulate Professor Quinones. He also became an associate professor as well. I don't know if he wants to tell people, but I'm telling you now, it's a good thing. So then in another 5 years, hopefully I can become an actual full professor. So just like Dr. Ovai is. So I got to do some more work on that, some more time. But anyway, thank you. You guys are so nice. Appreciate that. So anyways, let's talk about some common research designs that we see being used in epidemiology, and kind of how they're going to be used specifically for these purposes here. So you can kind of look at their objectives there. So again, our functions of research design, right? We're doing research. We're usually trying to answer some sort of question, right? So we're using our data here to see what is or was the frequency of disease in a certain place at a certain time, right? So again, you're probably going to be seeing all kinds of study coming out about the effects of COVID, because this is such a sea change in the way that people are living. You're probably going to find, studies looking at rates of depression, rates of divorce, all kinds of things, not even directly related to the disease itself, but just all the other societal things we've had to deal with as a result of COVID, right? So anyway, so again, all of the research we're doing here, whether it be quantitative or qualitative, is going to be descriptive, right? And you're going to see that when you're doing studies, it's only going to be as good as the data that you're collecting or the database that you're using there. So having really good sets of data is going to be really important there. I'll give you an example of this. When I was doing my study on coral snake envenomations, we have a system that we use at the Poison Center to enter in all of our cases. And so the system is really nice. A lot of it's like, free texting notes about what's going on with the patient, but there's a lot of check boxes you can hit. So if the patient had, they developed paralysis, you could click a box that says respiratory paralysis and click that. And so the issue is that if not everyone is actually clicking those boxes when they should be, and it was, again, sometimes inconsistent, then the data is going to be off, right? So again, the data that you're using is only, or the study designs you're doing can be great, but if the data is bad, it's not going to be a very good study. So there's oftentimes going to be rules that kind of govern how we're collecting and arranging data for this analysis, and that's, again, are called our research designs, essentially. So initially, we're going to have our hypothesis generation, where we're going to be looking to see some kind of question that comes up, right? Saying like, what is our the thing that we want to answer? You're going to do this in the summer when you do your research paper for your grad project 1, where you're going to be saying like, what's the clinical question that I have? Like, what's the best treatment for this disease state? Or, one of my favorite ones from last year was someone did to see if video games have any influence on, I think it was, or they're looking at virtual reality, augmented reality, and their effects on like surgical skills, stuff like that. So, you can really do your research on anything you want, but usually there's some sort of question here. And that's your hypothesis you're coming up with. And so then you have to test it, right? And so you're making a prediction based off this hypothesis, and whether or not the research, how it comes back, you either can test it again, which is ideal, or you can modify it or discard it based off the results that you get. And so you're going to see that some designs are better for hypothesis generation and some are better for hypothesis testing. And I think we touched on this a little bit at our previous, we were talking about that last journal club, that study where that was more hypothesis generating than it really was more testing anything specifically. And you'll see some designs that can be used for either, depending on the case there. But our basic function of these designs are either to try to describe the pattern of health problems, like that paper was when we were looking at the rates of, or the prevalence of developmental issues in kids. And then also we want to make, or you can do that, or try to make a fair, unbiased comparison between a group with a risk factor and a group without, or if we're giving a therapeutic intervention to one group and not the other, whatever the case may be, right? And so good epidemiologic study design should be able to kind of do the following functions here, right? So they should be able to do fair comparisons of a variable. So looking at things like disease frequency between two or more groups at a point in time. We could be between one group before and after receiving an intervention or being exposed to a risk factor. So for instance, if we're looking at a new vaccine to see, rates of disease pre and post, you could do that. You can do comparison of, it can be quantified either in absolute terms. So when you look at things like risk difference or rate difference, which you know about those, or they can do these in relative terms. So these are the type of comparisons they can do. And again, we've seen examples of these where you can either take the risk in one group, subtract it from the other, and that's a risk difference. That's an absolute quantification of a comparison, or you could do relative comparisons. You're doing one divided by the other. So that's either a relative risk or odds ratios most frequently, right? So, and then with that information, they permit the investigators to really determine whether that risk factor in the disease occurred if there was a temporal sequence between the two. That's going to be a good design if you can say, okay, well, I know the risk factor exposure started now, and then I can see whether the outcome actually occurred later, right? So again, getting that temporal relationship is important. And then obviously they want to be able to minimize bias, confounding, all the other stuff that may complicate your ability as a clinician to take away anything from that study and actually apply it back to your own patients. So some of the designs we're going to talk about, so cross-sectional surveys and ecological studies are pretty good for helping with developing these hypotheses. And we saw that as an example of that last journal club. Cohort studies and case control studies, right? Remember the differences between those two, are better used to develop hypotheses and then test them. Okay, so you can kind of use them for either or. And then randomized controlled trials, and we'll talk about field trials here briefly, are used basically to test out the efficacy of a new intervention. So usually like a new treatment, or if we're doing like a new education system or some kind of preventative measure to see how effective that's going to be. Okay. And so you can kind of come back and look at this again for your studying purposes. I'm going to go into the details on these as we move forward. So let's look at some observational designs for helping to generate our hypotheses and kind of how they can apply in terms of epidemiology versus where we're looking at it strictly before in terms of like clinical biostatistics. So as we mentioned, a cross-sectional survey is just a survey of a population at a single point in time, right? So if you called everyone in Orange County right now and said, okay, do you smoke or not? That would be a cross-sectional survey because you're getting that one point in time. Usually either done like through interviews or some kind of like mass screening program. So that was an example where in that last paper we were looking at where they, were basing off of a certain database there where they were interviewing these patients based off if they said, yes, my kid has a disability or not, right? You can mail out things, you could email things, you could do all these types of surveys here. Typically response rates are really poor, right? Usually you can see less than 50% response rates in a lot of cases too, because like I'm sure most of you are likely getting phone calls from people about the election or something. How many of you have ever answered one of those? I don't. I just say, cancel it out, or telemarketers and stuff. Some of those might be surveys, right? And so again, response rates are generally pretty low, and that's to be expected, right? So that's why they always report that stuff out. Yeah, sometimes they'll trick you. I hate when they use like the area code where my phone number is, but now I know no one from my place where I lived at when I got that number would ever call me. There you go. You actually did 2 of them. Well, there you go. So you're helping out with the response rate. So good on you. Regardless, though, in the study we were looking at, though, if you actually look at the response rates, they were really good because, again, they had census-trained people actually going out and following up with these individuals. And the census is actually a pretty good response rate, mainly because, like, it's kind of required by law to do them. Not that everyone actually does them, but we're, kind of mandated to do that. So it usually is going to be a pretty good response rate for that. That's probably the best one out of any of them you'll see. But some of the benefits of using a cross-sectional design are they're quick and easy, right? You can kind of get in, get out very fast. It's relatively cheap to do for the most part. And they're good for just determining prevalence of things like risk factors like smoking, for instance. If you want to look at the frequency of prevalent cases of disease in a population. And again, that could be defined however you want it to be, whether it be a geographical location, a certain type of people, whatever the case may be. And then you can also measure things like current health status, planning for some health services, so seeing where certain disease states may be more likely, so you can plan to maybe have interventions at those areas, and again, setting priorities for disease control. So that's kind of the easy things you can do or useful things you can do with a cross-sectional survey. Disadvantages, though, is that the data is going to be not the most robust that you're going to see out there. So not only are you going to have like poor response rates in a lot of cases, depending on which database you're using there, but also establishing cause and effect is going to be almost impossible. Being able to create those temporal relationships or determine those is going to be really difficult. And also there's another thing here too, which is really important, is that they select for longer lasting and more indolent diseases, right? So what I mean by that? Well, basically, if you have a disease that allows you to live for a long time, then you're more likely to pick that stuff up. So people can be hypertensive for a really long period of time, but if you get like, really late stage pancreatic cancer, you're not going to live with that for very long, right? So because of that, people who live for longer with a disease state are more likely to be measured than people who die quickly from it, right? So severe or rapidly fatal diseases are less likely to be found. That's called a Niemann bias or a late look bias, right? So again, another type of bias we mentioned here. And so another way we can call this is length of bias in screening programs. And again, you're going to be able to find less aggressive cases because, again, they're living for longer with it, and they're more likely to be found and available at that time of screening. Okay. So we can do cross-sectional ecological studies, and they actually are relating that frequency with some sort of characteristic like smoking and then an outcome of interest. So that's exactly what we were looking at with that study. So that's why a lot of people are saying, oh, I think it's a cross-sectional study, and you were correct, but to be more specific, it's a cross-sectional ecological study because you're actually looking at an area. In this case, in that article we were doing was a geographic area, is the US, right? Is that what they're using as their population there. And so then you can dig down even further. You could do a city, you could do a state, whatever you want it to do, depending on the study there. And they're good for suggesting those hypotheses, right? It doesn't actually prove anything, but it says, okay, well, maybe I want to do a more specific a study based off an interesting association that I'm finding in one of these cross-sectional studies. So, things like, there's no information as to whether people who smoked are the same people who develop lung cancer, because again, you're just getting a big pool of data. And it's unknown whether the exposures happened at the beginning or of the lung cancer, or what came first, right? So you can't really tell chicken and egg sort of associations there, because you can't determine the time frame, okay? And there may be other explanations for an observed association that you don't know about. So for instance, in that study we were looking at with the developmental issues, I didn't see any questions asked about things like lead exposure, right? Because certainly lead exposure can lead to a lot of developmental issues. So we don't know, right? So if they don't ask, then we don't know. That could be a potential confounder. So, there are cases in which these hypotheses are initially suggested by a cross-sectional study, and then they're later proved to be correct down the road, right? So, initially they're looking at the rate of dental caries in kids. They found them to be higher in areas with low levels of natural fluoridation, right? So low levels of fluoride in the water than areas with high levels. So they saw this association with an ecological study, and they're like, wow, that's pretty interesting. What would happen if we actually put more fluoride in the water, right? And so this is where you can see that, where they actually introduced water, fluoridated water, into these kids drinking water, and they found that they had less dental caries, right? So again, something that was suggested, a hypothesis suggested by an ecological study, then followed up with an actual more robust type of study design that shows cause and effect there. You can do longitudinal studies, and so these are typically used for like ongoing surveillance of things. So for instance, if you were to look for disease rates and how they change over time, right? So if we're looking at things like depression, you want to look at depression and the effects that lockdown had on that. You could be looking over time. What were the rates before we went to lockdown, and then what were the rates afterwards? Or if you introduce a vaccine, things like that. And so you can detect these sort of changes in disease rates, right? That's kind of you're looking for those trends over time. And so for instance here, the introduction of the inactivated polio vaccine and the oral polio vaccine resulted in a pretty precipitous drop in that rate of paralytic poliomyelitis in the US, right? And so because of this large number of people, they all got immunized around the same time there. They saw a relatively slow rate of change. And then, of course, other factors in the population can also be factored in, right? So do you have new people immigrating into a population, leaving a population, or the case may be there? And so longitudinal studies are helpful to determine those trends over time, right? So let's look at some observational designs for generating or testing hypotheses, right? So ecological studies, those type of cross-sectional studies, good for generating hypotheses. Now let's look at some that are better for testing and generating, right? So again, sometimes you can use longitudinal ecological studies for these. So, or in the cases here, here's an example of where using a longitudinal study helps suggest a hypothesis that could be followed up on later on. So looking at an example here, they were looking for about a 20-year period after so 20 years after there's an increase in smoking rates for men, they saw lung cancers actually going up as well, right? So they were looking at rates of lung cancer amongst these guys who are smoking. And then they also found that 20 years after women began to smoke in large numbers, that also the cancer rate went up for them as well. So the studies that we're doing were longitudinal ecological studies, where they're kind of detecting these rates, the changes in rates in lung cancer over that time. But again, they didn't relate the individual case of lung cancer back to the smokers, right? So they saw it was probably an association, but they couldn't say that was necessary cause and effect there. So the task they wanted to do then was to try to see, okay, well, is there an actual causal relationship? And they can do that using cohort and case control studies, which you already know something about because we've talked about them previously here. And so basically the cohort is going to be the people who have the disease in question. Using cohort study, again, we're going to be basing groups of people based off of their exposure to a risk factor or not, right? So cohort studies, we assemble them, either smokers versus non-smokers, people who have bad diets and good diets, whatever the case may be. And typically you're using a random sample of the population, or at least as random as you can get it. And again, looking at that baseline comparison between groups is important to ensure that you're comparing apples to apples there. And then after you have that cohort selected, you follow them for a period of time, and then you find out who has the disease of interest or not, right? And again, the whole point there is that you were measuring the risk factors at the beginning of the study and then looking at the rates of disease that occurred, right? So you're kind of following it in that kind of direction. I think I have some pictures here in just a moment that kind of illustrate that. But Again, the defining characteristic of these types of studies are that people are grouped into the basis of their exposure to an outcome or not, and then followed for the outcomes, right? So, whether they got a new experimental drug versus the gold standard, whether they got surgery versus no surgery, whatever the case may be, you're basing the groups based off of that risk factor. And then in contrast to case control studies, which are kind of the opposite, where you're starting out with the disease state in question and then looking backwards to see who had the risk factor or not, okay? So when you're looking at cohort studies, there are two types mainly. There's prospective types and retrospective types. I know most of the time you're going to be thinking about more prospective cohort studies, but retrospectives can also be have their place there. And so again, I think this is a good picture that kind of shows the general flow for these types of studies here. So in the example of a prospective cohort study, you assemble the groups based on the data on their risk factors, and then you follow them for the outcomes. You do the same thing for a retrospective cohort study. It's just that you already have all the information available to you. This is generally done by things like data collection from like electronic medical records. I did my study I did on coral snake envenomations and fellowship was a retrospective cohort study where actually I grouped people based on whether they got antivenom early or they waited to give antivenom. So those are the two groups. The risk factor was whether they got antivenom early or not. And then I followed to see what kind of outcomes they had. Again, that's relatively easy to do because I didn't have to actually like envenomate people with coral snake bites and then follow them to see what happened. I could use a large data set. I think we only have like 50 some odd coral snake bites a year anyway. So it's, again, I had much bigger numbers that I could use with using historical data, but there's some downsides to that as we'll see. And then case control studies, again, you're starting and assembling cases and controls based off of their outcomes, cases having the disease in question, controls not, and then looking backwards to see, did they have the risk factors, okay? Again, if you're doing something prospective, the strength of that causal relationship is going to be stronger than collecting data retrospectively, mainly because there could be bias introduced due to like detection bias and things like that, recall bias, all of that. Versus if you have really good study design doing a prospective study, it's a stronger case you're making there. More difficult to do though, time consuming, costly, etc. So, as I mentioned, in a prospective cohort study, the investigators assembling the groups based on, at the present time, collecting data on them. And then again, it can last for years in some cases, maybe months. Just depends on how they want to do that. So, for instance, like the Framingham Heart study is a really good example of a really long-lasting cohort study there. And then some advantages here is that they're able to control for things. You're able to, get consistent data collection. You're able to make sure that things are running smoothly as the study progresses there. They're able to estimate risk, which is really good. So you can actually get absolute differences in risk. You can look at relative differences in risk. All that's very handy to be able to tell you, okay, well, it makes it more generalizable as well when you apply that out to the population at large, right? And you can look at a lot of different disease outcomes. It doesn't have to just be one outcome. It could be many. So if you're grouping people based off of smoking or not smoking, you can follow them for oral cancer, lung cancer, hypertension, heart disease, whatever you want it to do. You can do as many of them as you want. So some disadvantages of cohort studies are going to be the high cost, the long time you're going to be waiting there, possibility for people being lost to follow-up, which can skew data for sure, and all of that. So also when you're doing a prospective cohort study, you kind of have to know what risk factors you want to look for, and then also the outcomes that you're going to be measuring, because you don't want to change midstream, because that's going to invalidate all the previous data that you were collecting there. So something to note. Looking at retrospective cohort studies, again, I did one of these. Nice because you're collecting data retrospectively. The data is all there. You just have to kind of go through it and collect the information. There will be some challenges with this, though, as you'll see. One example of this would be if like an investigator looked back in history to define a risk group. So, for instance, people who were exposed to the Hiroshima atomic bomb in 1945, and then compare that to group members who were not exposed to it, and then looking at things like cancer risk and death, for instance, right? So again, you don't want to do a prospective cohort study where you blow up a bomb unless you're like living in the Fallout universe or something. But point being, this is one that would necessitate doing sort of a retrospective design here, right? And again, relatively quick and easy to do. You can do relative risk, you can do absolute differences risk, and all of that, because again, you're sort of setting up your groups already and grouping them based on that exposure to the risk factor, right? However, I can't really do anything about the data collection process because the data is what it is. So if you have people who are not collecting data the same way, so this is where different people may collect data differently, then that can skew the results. If people forget to check off that someone had a certain case of cancer, that again can skew your information there. And then case control studies too are going to be done typically for disease states that are quite low in number. So if it's something that's like an orphan disease that really doesn't happen very frequently at all, these can be useful there. So you can basically group people up based off of if they have the disease or not. So your cases are people that have the disease, controls are people who don't, but match the cases in some regards, right? So you're matching them based off of generally like age, ethnicity, race, things like that, gender, I should say. So you're helping them to look similar to the cases. So that way you're trying to control for some of those variables. So that way someone who has a really rare disease that's 20 is not being compared to someone who did not have the disease that's like 60. Again, you want to be able to control for those sorts of things there. And so note there, you can't really get differences in risk when you're doing a case control study. You have to use odds ratios because you're looking at the odds of that person with the disease state having a risk factor or not. Okay, so that's the important thing there. Risk factors or odds ratios are used for case control studies. Looking at differences in risk and relative risk are going to be used more for cohort studies. So again, we're grouping them based off of they have the disease or not. Remember that you don't want to overly overly match patients, because sometimes you can make them so similar that it's really difficult to look backwards to see if there's any changes in the risk factors there. So there's an idea of overmatching that can come up, but it's not super common. You'll see that. And again, too, the time relationship is not going to be really clear here as well, because usually when you look back at that risk factor, it's either like a yes or no. Did they have it or not? And it's difficult to tell. Did the disease come first? Did the risk factor you're looking at come first? You can't make that established. You cannot establish that temporal relationship as easily as like a cohort study. So that diminishes some of the strength of these study designs here. So you'll find that when you're doing case control studies like this, you can make some of the advantages relatively quick, relatively inexpensive to do, because again, you're using retrospective data just like you would for a retrospective cohort study. But again, it's good for disease states to have like a prevalence of less than 1%. So really rare sort of things you want to do that for. Other things you want to note too is that for case control studies, really only one outcome is being considered, because that's what you're grouping your people based off of. But many risk factors can be considered. That's kind of the opposite of a cohort study, where with a cohort, you're doing it based off of one risk factor, and you can look at many outcomes. Here, you're only doing one outcome, but many risk factors. So there's also a difference in some of the things you'll see with that, right? So, and again, you could also do something like a case control study for like the one that we were looking at for the developmental issues, right? You could design a case control study where you start off with kids who have autism spectrum disorder, and then look backwards to say, okay, well, how educated was the mom? Where do they live at in terms of the federal poverty limit? Things like that, and that will, you can get some inferences from that. So, all right. Again, disadvantages. A lot of potential for recall bias, especially if you're interviewing people or working off of medical records that are not complete. And again, it may not be really easy to get the adequate control for your cases, right? So again, what are you controlling for? What are the factors you want to actually control for there? If you don't do the correct ones, you may introduce some confounding there, right? Again, as I mentioned, they're usually matched based off of things like age, sex, and race. But if possible, we should also match controls from the same diagnostic setting, things like that, because the more similar you can make them to a point, it can also help to find real differences in terms of their risk factors. All right, a couple other things here. So looking at some experimental designs for testing hypotheses, we'll talk about randomized controlled trials versus randomized controlled field trials. They're pretty similar in terms of their design, but you'll already kind of know what a randomized controlled trial here is. Again, these are the strongest evidence that you can have for a causal relationship here. Big difference between the two, though, between a field trial versus a clinical trial. Clinical trials are usually some sort of therapeutic intervention, and people have a disease in question. Field trials are more often done for like preventative interventions for people who are healthy and trying to prevent them from developing a disease, right? So if you wanted to introduce a new program where you were giving out, for instance, like free screenings for a disease, that would be more of like a randomized control field trial, for instance, right? So that's the big differences there. Again, how are the studies set up? Well, you're going to recruit people into the study. They get randomized into one of the two groups. Either they're getting the experimental intervention or they're getting a placebo or some sort of control, whether it be standard treatment of something or placebo, whatever the case is going to be. Again, the groups should be similar to one another if you've done a true randomization there. And then you look for the outcome. You see what happens between those people there, okay? And so, again, the intervention group is getting the experimental treatment, and then the control group is getting not that, right? So remember, the control group is going to be dictated based off of what's ethical and also what sort of standard of care in some cases. So for instance, with like HIV studies, you could not have a control group that got placebo, right? Because it's not ethical to withhold antiretroviral treatment in that patient population. So they would be on some sort of standard treatment versus a new experimental one, for instance, right? So, and again, randomized controlled trials are the gold standard for studying those interventions to determine cause and effect relationships. Remember, they don't entirely eliminate bias, but they help to control for a lot of that stuff, right? But again, there can be some challenges too with the ethical dilemmas for investigators. Like I try to do studies on PA students all the time, but they keep telling me that it's not ethical to, envenomate you guys with coral snakes, and so I just can't do the studies I want to do. It's like, what the heck? Trying to stymie my intellectual curiosities here, but I guess it's safer for you guys overall, so that probably works out. Anyway, so remember, for patients to be enrolled in a randomized controlled trial, they have to agree to it, right? So consent is extremely important. They have to understand what the risks are of getting into a study, what the potential benefits are, and the fact that they can leave whenever they want, right? And there also are going to be controlled, protected groups who cannot be in a lot of these studies because of the undue sort of risk you'd be putting them at, or the potential for coercion to participate, right? So you couldn't really enroll prisoners, for instance, in a randomized controlled trial, even though it's a very easy to control patient population because they're not going anywhere, right? You can monitor them very closely. However, it's not really ethical because if they think that they're going to get, a more lenient sentence if they participate, then that might, coerce them into doing that. You can't really do it. So there's certain groups you're not allowed to really do studies on, or if you are, it is very limited in a lot of cases. Now remember, blinding is extremely important to make sure that when the researchers don't know what groups the patients are in, and then also the patients don't know what they're getting either, because that equalizes out that placebo effect. You can see that, okay? And again, for true blinding, the non-experimental treatment needs to be almost as identical as possible. If you recall back to that study we were looking at with S-ketamine being used for depression, you also saw there that they tried to add a bittering agent because it was an intranasal medication to simulate that. But again, they don't really know if it was really one-to-one. So patients might be able to really determine which group they were in, right? Or as I mentioned, like my dad participated in a trial for a COVID vaccine, and he felt so miserable afterwards that he was pretty well sure that he actually got the vaccine. I'm pretty sure that I don't think any amount of willpower could have given my dad the kind of the aches and pains he was experiencing, the low grade fever, that a placebo might do. So he's pretty easy to tell that. So true blinding though they should be identical. Now, as I mentioned, you don't want patients participating in a study that involves like a surgical intervention, because you would basically have to do a sham operation, although there are some limited cases where that can happen. So I've seen some studies where there was a control group that got lumbar puncture, basically saline was injected, because it would be pretty easy to tell whether or not patients got a lumbar puncture or not, basically, things like that. But in studies, with non-surgical interventions, typically it's easier to get an effective placebo, right? So you can put things in capsules that look very similar to one another, and you wouldn't really be able to tell a difference there. And again, as I mentioned, it would be unethical to do a study if the intervention was strongly believed to be available, whether or not it has been established scientifically. So, one of the other things too is sometimes we'll stop studies early on the basis of ethics if we see that the intervention is so effective, right? Sometimes studies, like a new drug, shows that it's so effective that we stop it early because it's unethical to withhold that from the people who are getting placebo because they're getting such they're not getting the benefits of that medication. So it's kind of fun to see that when you're like, wow, this drug works so good, we gotta make sure we give it to everyone. So again, in those two groups being compared, there may be different rates at which the patients drop out, and that's important to consider. So how many patients they started with versus what they ended with is important to consider. If there's a high rate of dropout, that may be biasing the data to some degree, and that's something we'll see with intention to treat analyses where they try to include the people that dropped out and then they exclude them and they try to compare the results there to see if they are relatively equal. But some reasons people might drop out, or, for instance, if they feel better, or, they may stop treatment early. If they have bad side effects, they may stop early, things like that. We can see, especially too in severe diseases, or if they have like advanced cancers and things like that, patients may just get to a point where they just don't want to try anymore. Like they are more transitioning more to more palliative care, and they just decide they don't want to participate, and they're totally allowed to do that. Or as I mentioned, with unpleasant side effects. So if you're getting a new antihypertensive drug and you develop erectile dysfunction, I probably wouldn't want to hang around in that study much longer after that, anyway, right? So other kinds of bias you can see with randomized controlled trials include things like publication bias. This is a really important one, and there's I think there's like a John Oliver episode about this. You can look up on YouTube if you're like that guy. But publications typically want to publish positive results or actually find something. It's a little anticlimactic to read a big study and they say, oh, well, we found nothing, right? But those are still scientifically important to show that, if something does not have an effect, right? So because of the fact that a lot of studies don't get published that are negative, that leads you to maybe thinking something's really effective when, you read one study where something looks really good, but then there's 3 other ones that never got published that look bad. So that can be a challenge because it may lead you to some spurious conclusions there. Okay. So again, looking at those field trials, as I mentioned, usually going to be done for some sort of preventative thing, new education program, new screening program, something like that. And again, they would just be randomly either getting the preventative measure or they would get some sort of placebo. So either got the education or they didn't, and then looking for rates of disease afterwards. So a little bit of difference there in terms of what they're used for. Examples of a randomized controlled field trial would be something like vaccines, because again, we're giving you something to prevent a disease from occurring, or if I was giving aspirin or something to try to prevent cardiovascular disease. Challenges, though, is that it can take a long time for these things to occur, right? So you give aspirin to someone who's, say, 40 now to prevent cardiovascular disease, you have to follow them for decades before you'd be able to find a difference, right? Or before the event would actually occur. So another disadvantage too has to do again with the external validity or the ability to generalize their findings to other groups of people. So there's one study that was done. There's a really big study called like the Physicians Health Study. I don't know if I have a slide on that or not, but they had these male physicians who they were giving, I think, vitamin C2 and aspirin or something like that. And it was a huge study. It was a lot of people were involved with it. They found really good results, but the problem is it was generally like all males. There were older individuals who were physicians, so they had higher degrees of education. So it really, obviously if they're physicians, you'd assume they'd be healthier on average. Not all of them are, but certainly some. And so the issue with it is it wasn't very generalizable. I couldn't really generalize that to my grandma, for instance, who is not a white male physician who takes care of herself, So, generalizability is very important. That's why you want to read the methods to see who they're including in the study, who are they excluding, because that may make it not very generalizable to the patients that you take care of yourself. Okay, so that's one of the other big things to note with your randomized controlled trials. So, luckily I got through that on time. So we have 2 more that we'll hit tomorrow, and then with our 3rd and final journal club, and then we'll have our review next week, I think. So let me see if there's questions here. Let me see here. So someone asked, would you be willing to switch journal club 12:30 tomorrow and then do the lecture afterwards? I don't know. That's a question I have to check on with Professor Lack, perhaps. I will look into that, and if I do, I will make an announcement for everyone. I'm not sure if people already have plans to be available at 2:30 or not. I will check on that. So probably email Professor Lack after this. But anywho, any other questions from you guys? If not, I'm done with you for the day. Thank you for joining me, and you may all have a wonderful afternoon. Guys, have a good one. Yep, see you tomorrow. 4 days in a row with me.